Good evening, everybody. Welcome to our webinar, Overcoming Data Paralysis to Address Health Inequities. Health inequities are not actually a new thing. There's evidence of health inequities dating back at least to the early 2000s and probably well before that. However, progress towards addressing these inequities has been disappointingly slow. So to discuss some of the issues and perhaps explore some of the barriers and explore how we can move forward to improve this situation, I'm joined by an esteemed panel. We have Dr. Chinwoke Iziguzo, who is Director of Monitoring, Evaluation and Learning at the Palladium US. We have Rosalind Ate, who is State Network Director for Unite Us in the US. We also have Dr. Khadija Owusu, founding member and director of programs at Melanin Medics in the UK. And finally, we have Dr. Shalini Mohan, head of health equity and inclusive research at Genentech in the US. So welcome, panel. We want to get straight into our discussions. So I'm going to start with our first question, which is going to really be to understand what first prompted you to get involved in health inequities, and most importantly, to actually take action. So when did you first become aware or conscious of health inequities, and what prompted you to really get involved? And I'm going to start with Shalini.
Thank you. I would say that it links back to a time when I was in clinical practice and I was caring for an African-American woman who had several risk factors for cardiovascular disease. And we were reviewing the Framingham risk score. And she actually asked me a really great question. And that was if the score was actually based on people like her. And I paused for a moment and I had to answer no, but I will be forever grateful that she asked me that question because it's helped shape my career interest and my current passion. So when I serve as the head for health equity and inclusive research, it's often my responsibility to think about who the patients are that we are not including, those who are missing in the data. And as the healthcare system becomes more focused on PHC or personalized healthcare and relies on data insights to inform the next best action or where those data gaps are or inequities are, it becomes really critical that we ensure that all patients are represented so everyone can realize the benefit of personalized medicine. That's really where my journey began.
Thank you for that. And it's great really that right from the very start, you remind us that actually this is about the patient. We can get caught up in the numbers and the data and the evidence and the systems and the processes, but actually what we're trying to achieve is better outcomes for that one single patient who is at the center of our care at any particular moment in time. Next, I'm going to go to Khadija. Could you please tell us, what first sort of prompted your consciousness about health inequities and stirred you into wanting to do something about it?
Yeah, sure. I would say for me, it's happened a bit earlier on, halfway through medical school at the time where we was beginning to set up Melanin Medics. I mean, initially our primary focus was on diversity and representation amongst medical professionals. But then once we started to look more into the issues, then you realize that the issues pertaining to diversity and representation goes beyond their workforce. What about the patients that we actually look after? And that's where I sort of began to delve a bit more into health inequalities and understanding a bit more about it.
Excellent, thank you. And next I'm going to go to Rosalind Ate. Could you tell us a little bit more about your experience?
Yeah, sure. Well, my story goes way back to when I grew up in Nigeria. So I remember, and I tell this story all the time. I remember back then I would be walking to school with my brother, and we would walk around a community who didn't seem like they had the resources that my family had. And at that very young age, I was very baffled. And I would ask my parents questions like, why don't they have access to water? We have running water. What's going on? But at that time, my young mind registered that there is something wrong here. And knowingly or unknowingly, that's what shaped my career path, right? So I went to undergrad for public health. I didn't even know what public health was back then, right? So I wanted to be a doctor, and I thought that that would be the way that I could make people feel better. but I knew that there was something else that was missing. And I wanted to be part of the solution on ground, understanding people, understanding that their stories and their situations. And that's basically what has shaped my career path until today. And that's where I find myself, in communities where I'm just being of service to people.
That's great. And isn't it great how those early experiences really shape how we develop and what we become interested. So finally, on that question, I'm going to go to Chinwoke.
Thank you very much. And I'm also from Nigeria, and the stark reality is that health inequities exist in Africa, and many of the factors that influence health inequities in Africa can be grouped under demand and supply side barriers. So it was easy to see some of the solutions, although we weren't seeing them. And this motivated me to go into public health, even after training as a medical lab scientist with a major in hematologist. So after some time, after working briefly in the hospital setting, I went and got my degree or my master's in public health. And fast forward, of course, I was working in that space for a long time. And interestingly, fast forward, when I moved to the US for my PhD, and in one of the classes, I saw the data on maternal and child mortality, where Black women are 3 times more likely than white women to die in childbirth, and Black babies are nearly 3 times more likely than white babies to die in infancy. And overall, Black Americans live nearly 6 years less than white Americans. That also pushed me to focus on maternal and child health equity during my dissertation, and that has influenced most of the work that I do here in the US and even outside of the US. Thank you.
Thank you, Chinwoke. And you mentioned there that you saw data of health inequities within in terms of maternal health for Black women, and that really brings me back to the statement I made in the introduction. Health inequities is not new. It's not a new phenomena. It's much more in the consciousness now, but there certainly has been that evidence and that data for a substantial period of time. So I'm going to start with you, Chinwoke, and ask, what do you feel has inhibited really more rapid progress towards improving health equity for diverse populations, despite this abundance of evidence?
Thank you for that question. And just like you said, I would like to reiterate that the persistent racial disparities that we see across all health outcomes, especially most of my examples might be coming from the US, they are not new. It's been persistent, and there are some deeply concerning trends that we also see in maternal deaths in the US. I'll give an instance. In the last 1 year, we saw a 40% increase from 2020 to 2021 in maternal deaths. So these things are persistent. We're seeing this glaring health inequity. And one of the major things when you look at this data is that when you control for education, when you control for income, when you control for all the socio-demographic figure, all variables, the racial disparity still persists. And that is where the issue of racism comes in. Maybe we're not measuring what we're supposed to measure. Maybe there are still some other things, that we should look at that could tell us the story. And we think that even some of the work that we're doing, and if we don't focus on racism, if we don't focus on making sure that diverse groups are empowered to speak, are empowered to make decisions around their health, we won't move forward. We won't move forward to achieving health equity or great health outcomes among this group. So I would say that things like racism, things like discrimination have inhibited racial equity among several groups, especially in the US.
Thank you. And hopefully, moving forward, we're going to look at that, explore how we might address some of these barriers and issues. But before we go there, I want to just hear from our remaining panel in terms of, what do you feel are some of the salient things that have contributed to this sort of stalemate in terms of moving forward and improving health outcomes? So I'm going to go to Rosalind first.
Yes, thank you. So, I'm also very passionate about maternal health. And here in New Jersey, where I live, the statistics are just absurd, right? But one thing that I think that needs to be focused on is a lot of health interventions are built for short-term focus, right? So you would think about, like, I remember when I was at a different organization, we would get grants, right, for different programs, but the grant cycle only lasted for, I guess, 2 years. And then whether or not you did well, it doesn't matter where you're going to get it, whether you're going to get it the next cycle, right? So then what you're trying to address, you can only just focus on it because then your funding has ended, right? So really looking at, how do we continue to make programs that are addressing health inequity sustainable, right? Because we need to make sure that the programs last. It could be 10 years, like you said. This is not a new concept. It has been here for a long time, right? But how do we make sure that those programs that are addressing these issues are sustainable? And additionally, right, we need all the stakeholders. One thing that I love to say is everyone needs to be at the table. Like when we're having conversations, so the data analysts, the community engagement managers, the community members, they all need to be at that table where we're all discussing how can we take this data, how can we take what we have and implement it into action.
Thank you. Shalini, I'd like to hear your thoughts on that. We are going to move along and sort of explore how we can, what we can do with existing data and things, that knowledge that we already have. But in your experience, what have been some of the barriers and the hindrances to more rapid progress?
Well, I agree with what's been said regarding sustainable funding sources, and also perhaps like racism and unconscious bias contribute to this. Certainly, there are bright spots or examples where there is tremendous effort and success stories happening, but this is not happening consistently across the healthcare system. And it's not for lack of data. I think that, we've cited statistics that are staggering, and I think that there is some awareness of that, but I think there needs to be a mindset shift that it's unacceptable that there are individuals that are disadvantaged based on who they are or where they live, and that defines their entire health trajectory. So we need to elevate this topic beyond this is a gap or a disparity that we simply accept or keep measuring in quantifying it, but rather the desire is that there is no gap.
I really like that. I really like the word unacceptable. Just changing and having a culture shift of that mindset that we're not now saying, oh, we have the data, we know about it, but it actually becomes unacceptable and therefore prompts action. I'm going to just ask Khadija to comment finally on some of the barriers that might have hindered more rapid progress.
Definitely. Now, I think what everybody else has mentioned is correct. And also, it's important to know that once we do get the data, we already know if it's, if it pertains to the UK, around the height of COVID, Black mothers were 5 times more likely to die from to experience maternal mortality. With the rates of COVID-19, if you were Black, you were up to 4 times more likely to also die from COVID-19. So when the issue is when we do have the data available, when we do have these statistics, not much is being done, as you've mentioned. And this is where I look at it from the angle of, okay, well, who is sitting at the table whereby you've received the data and you have to then implement, not only make recommendations and points of action, but who is actually therefore going to take and make, the action that is required. So when we look at the cohort of our boards, it's not representative of our population. And this is where inattention comes into place. Issues that predominantly are affecting, let's say, quote unquote, the others will not be placed at the forefront. We know that this is a serious issue. Because of inattention, it leads to inaction because there is a lack of perception. There aren't individuals, or there is a lack of individuals who share those lived experiences in order to make those recommendations in order to better the outcomes for our communities. So another key point that hinders as to why, you know, health inequalities still persist is if we look at the representation of our boards and their makeup, it's not accurate and representative of the population.
So thank you, panel. So, you know, we've heard there are a few things around what has hindered progress in the past, or more rapid progress. So when we thought about data paralysis, we thought about this, you know, abundance of evidence, yet somehow, you know, we seem paralyzed in terms of taking action. So we've explored the past and what might have prevented that. But as we say, there is an abundance of evidence. So we want to look at, you know, with the data that we have, what can we do with that data to help us overcome this paralysis, this inaction, and to actually start to address and to effect real change in terms of health equity for diverse populations. So I'd like to ask, you know, how can we make the most of currently available data? You know, it might not be the perfect data, there may be flaws, and often those flaws can be used as an excuse for inaction. But with currently available data, how can we use that and best galvanize that data to sort of move us into real change? And I'm going to go to Khadija for that question first.
Sure. So with my experience in relation to Melanin Medics, which is a non-profit organization in the UK, to the UK's, which is basically the UK's largest intergenerational charity for African and Caribbean medical students and medical doctors. And so I'll be speaking in relation to, or from the perspective of grassroots organizations who predominantly engage with these communities. Another example is the 5 Times More campaign, which is a group of mothers who also work towards reducing the health inequality in relation to Black mothers. We have this abundance of data. Let's say individuals or the key decision makers in a way may not know what to do with the data pertaining to our community. This is where you then have to involve and utilizes the key voices of the community, key voices of grassroots organizations who work directly in these communities with these individuals. And if it's the case of, well, we need to implement sustainable funding for these organizations in order to continue the work that they do, in order to make sure that we build communities that are more trusting of the health services available, more trusting of the scientific institutions, then that is definitely one of the ways that we can move forward. So I think it's definitely, in conclusion, utilizing the knowledge, experiences, and the key voices, centering the voices of those who work at the ground level, grassroots organizations with the communities in order to make sure we all work together.
Thank you. I'm going to ask Shalini to comment on that. What do you think are, you know, that we can do really to support, you know, how can we use the available data that we currently have? We've talked a lot about, you know, there's no shortage of data. You know, we've talked even on now about on this webinar about, you know, disparities in maternal care. So this is very much known. But how can we use this data? Is there a way that we can use data to effect more rapid and greater change?
Absolutely. I think that the available data that we have will still enable us to take an innovative approach to reshaping or rethinking how we conduct, say, day-to-day or core activities. So from the pharma perspective, I can share that when we conduct sponsored clinical trials, we're using data to help inform the study design, the areas where we place the trial so that we can find those patients that are the ones that we're focused on getting and recruiting into a study. So we're using data insights to help shape how we conduct clinical trials in a very novel way. But I say novel in that it's something that we haven't done to a great degree previously as an industry, but now we can use the data that are currently available to do something a bit different. So when we set up a clinical trial and we know the FDA is requiring us to include more diverse populations in clinical trials, we actually have data that can enable us to do so, and we've successfully demonstrated that it's possible. So I think that's one approach, is rather than highlighting what's missing in data, is to take the data that we have to do things a bit differently. I'll just finish by adding that whenever we do look at data and we define that there are gaps, that inspires an opportunity to develop new data capabilities. So that means that the next generation of data, if you will, doesn't necessarily have to include those gaps. By raising awareness of the gaps or the bias that the data sets could hold themselves, we can then employ things like expanding our case report form. So the data that we collect out of clinical trials can be modified to include things like social determinants of health or sexual orientation and gender identity, so that in the future, we'll be able to better understand the patients that do participate in clinical trials and are represented there at a much more granular level.
Thank you. I really liked the idea of not focusing on what's missing, which I think is a default for the position that's easy to fall into, but actually focus on what is here. Yes, we do need to address the gaps, but let's first focus on what is here, and then how can we fill the gaps. I'm going to go next to Chinwoke on that. How can we make the best use of available data that we have now to actually start to make a change?
Yeah, thank you for that. It's good that we're acknowledging that we have tons and tons of data out there. And one of the things I would suggest is that we should also start looking at data sharing. So a lot of this data is siloed, like my organization might collect information on this. Another organization might have like access to this amount of data. So until we start sharing data, we may not make the most out of what we have. We have this example in the US where medical claims are now being integrated, or we get data from on social and economic conditions and integrated into medical claims to give us more bigger picture of what is happening. So we need to share data more. We need to be more open with what we have and not just silo it within our organizations. And also, I think another way is also innovative ways of analyzing what we currently have, like platforms that aggregate data from wide variety of government claims, assessment data. We have tons of information out there. We need to be innovative in analyzing what we have. Occasionally I bump into some great work that organizations like RAND is doing, where they pull data from, the Social Security Administration and use it for other purposes. Like, this is something that we want to see. So this is one of the ways we can make use of what we currently have, and not just leave the data all siloed and, still go about doing further researches, still go about doing further data collection when the data that we need might be sitting in another platform.
I love that answer. I really like the idea of breaking the data silos that we have. And, it's the old adage of being stronger together than apart. Rosalind, would you like to add anything to that?
Yeah, just sure. I mean, they've said it all, but one thing that I want to add, or two things, is we need to take this data and also think about how do we begin to invest in prevention? How do we identify the social determinants of health and risk factors that actually contribute to these health inequities, right? So that data is not just sitting there. We need to develop early intervention strategies, right? To make sure that we are actually attacking this. In public health law, we talk about the upstream approach. Can we get to the root cause of these issues, because the data is already shown, and begins to do those early intervention strategies. And another point is just really advocating for policy change. So we have this data. How much policy work are we doing with this data? Making sure that we are advocating for policy change that is promoting health equity, presenting this evidence-based argument, right? Because you go in, you want to present this this is what the evidence is. No one can deny the data, right? This is what it says. And how can we continue to advocate for policy change with the data that we have?
Thank you. And I also like the idea, of policy change. This is not just something that individual clinics and hospitals and even, per se, states and cities, but it just really needs to go perhaps to the heart of government and really affect policy change. I'm going to step back to really something that Shalini said in her opening, when you talked about that one patient that asked you, about that specific analysis, and was that analysis done in people that look like me? And by way of introduction to looking more specifically at clinical trials, we hear time and time again that clinical trials are not representative of the populations that medicines necessarily will treat. So what can we begin to do, Shalini, to address some of these data gaps in clinical trials? And we're sort of now looking at moving forward. So looking at the future, because we've dealt with the past, we've sort of looked at what we can do with the current data. But I want to maybe change focus a little bit and explore how we can ensure that we have better data moving forward. So what actions do we need to take now? So just focusing a little bit on the clinical trial data, what actions do we now need to take to ensure that we have better data for the future?
Yeah, it's a great question. I think it actually ties in a lot of the comments that we've made today, because we understand what the gaps are. We understand where our desired future state is, to have our trials be representative of the patients that experience disease. What we are missing is a systemic, like in the system, there are barriers that patients face. And whether that's at the patient, the provider, or the institution level, we need to be able to understand them and co-create the solutions with those communities in order to be able to get adequate representation in our clinical studies. So what I mean by that is, for example, we need more providers that are from diverse communities to be able to care for these patient populations, because we know and we have plenty of anecdotal evidence that suggests that patients who are treated by providers that look like them or from their communities have a inherent trust built in that may make their participation in a clinical trial more feasible or viable or of interest to them. That's one. I think two is designing better studies in the future. So that means like making sure that the endpoints are relevant to all populations, or at least the target patient population we're trying to reach, ensuring that they're simplified so that the study design is not so complex that they can only be executed at certain academic centers or institutions with those capabilities, but rather they can be executed at sites of clinical care sites where patients are actually receiving their care, for example, in the community setting. And then there needs to be a return of value to these patients in terms of data or insights, or they need to have a closed feedback loop. So they participate in a trial, we convince them, we improve their health literacy. They need to understand what they contributed that will help the future state or other people like them. So I think that this is a holistic approach that we need to take to be able to enable this. It's not enough to just say we want to have it, or we would like the data to be representative, or we just need to convince patients to participate in clinical trials.
Okay, thank you. I like that. So it's about looking how we can facilitate that participation rather than merely inviting it. Chinwoke, would you like to comment on that?
Sure. This is also something I would piggyback on what she just said. We should also look at other ways to collect the data that can also improve the health outcomes of diverse population. We have instances like community-based participatory research. She just talked about trust, and this is one way to actually engage the community in all the phases of the research process, including identification of the need for the investigation, the design of the study, implementation, analysis, even dissemination. One of the things that we have seen is that programs or actions like the community-based participatory research is really underfunded. And this is what we're saying. Stakeholders, people like NIH funders should really invest in these type of approaches or programs, because one of the things that we see is that it holds great promise for producing more useful and culturally appropriate interventions as well as information. And another thing is also, we should also be open to, I've started advocating for this in this last couple of years, open to qualitative data. There is power in qualitative data. I know that a lot of us find quantitative data more rigorous, but we, maybe the researchers, people who are implementing programs or stakeholders should embrace qualitative data. There is storytelling can be very powerful. There are other forms of qualitative data that we can collect. I've seen photo voices, I've seen visual voices work well in communities that are marginalized. So we need to, have that inclusion, include more qualitative information as evidence, because one of the things that we know is that they can cultivate more equitable power and even counteract negative stereotypes. So we should embrace this other forms of data that we can collect, and not just focus on gold standards like the RCTs, like experimental studies. Let's also embrace this other types of data collection, because we see it work, especially in diverse population. And especially when we can oversample for the RCTs and this other surveys, we can get the smaller group of people, talk to them, use other means, photo voices, visual voices, concept mapping, and get information from them. Thank you.
Thank you so much. So we heard from Shalini how we might collect more inclusive data and how we might encourage participation from diverse populations. And we've heard from Chinwoki that maybe we need to think a little bit differently about the data and actually be a bit more open-minded and collect different types of data. Rosalind, is there anything else that you think that we might do to improve data collection so that we have better data moving forward and more inclusive, stronger data that can be used to impact change?
Right. So I want to go back to the first point I think that Shalini made earlier about making sure that the population looks like the people that are providing the service. And I think another part of that is culturally competent healthcare delivery, right? So not only do they look like you, but also in the case that they don't, right? Are you going to provide care? Are you going to do research in a way that is culturally competent, right? In order to understand and address the needs of the diverse populations that we're trying to reach, right? So this includes respecting the cultural beliefs, right? As we're collecting this data and as we're providing the programs, respecting the different types of cultural beliefs that are on ground, understanding the health disparities that currently occur, understanding the story of the people that are currently there, and also employing culturally competent appropriate communication. How are you speaking to folks, right? At what language level, right? Are we speaking? So also talks about literacy, right? Health literacy. So making sure that the care that's being delivered, making sure that the way we're collecting this data is done in a way that it honors the people that live in those communities.
I love that. I love that about honoring the communities. We've talked a lot about data, which is, of course, the topic today. But I want to move on maybe a little bit from the data and consider just more broadly how we might begin to impact change. And I'm going to ask Khadija to comment on, things that we might do outside of data collection to effect the change that we need to see.
Thank you for the question. So, of course, having the data is important, but I think how we then manage and utilize that data to, whether it be change what we do in for clinical management, right at the front door in hospitals and clinics, in relation to who manages the data moving forward, how that affects medication that we then go on to prescribe to our patients. I think all those are very, very important. And it just sort of goes back to the point of who is managing the data. Are the people managing the data fully advocating for these communities and ensuring that we then come up with adequate actions and recommendations that need to be put in place? And just to echo what Rosalind said, in relation to sort of the data and research, a lot of the time, or majority of the time, our communities, when it comes to just even hearing the words research or data, immediately you shut off because you think, well, that's boring stuff. I don't care about data, I don't care about research. And so it's about breaking down this complicated information for lay individuals in their languages and ensuring that they fully understand, and whether that means recruiting community champions and going back to the point of grassroots organizations. For example, let's say with the case of Merriman Medics, we have the National Institute for Health Research in the UK, and they're a key partner with us because we know that the data says, well, if you are a Black doctor, you are more likely to experience less career progression because you're more likely to fail your exams. It's us that we know, okay, well, this issue particularly affects Black medical doctors who we work with. This is the solution that we are coming up with, a particular program that incorporates mentorship as well as sessions that can help, Black doctors be able to succeed. What are we missing? The funding. And that's where big corporations come into place, where we work hand in hand in order to make sure that these inequalities that already exist are tackled. So it's a much, much more likely a collaborative effort that is required here, not just when it comes to data, but everything else as well.
So that's really great. And I think if I was to summarize what I'm hearing from all members of the panel is about conducting more inclusive research, whether that be in terms of having clinical trial professionals be more inclusive and a more diverse population. We mentioned looking at health literacy and ensuring that potential clinical trial participants are actually enabled to engage with and understand the clinical trial. So we're sort of hearing this really complex picture, and how we move forward will take efforts across the board, different stakeholders, etc. I want to, in our sort of closing few minutes, consider the question, a couple of questions really. The first of all is, are there any questions that you believe that we should be asking, or any topics that we really should be asking and talking about that we are not currently addressing? Are we missing anything? Shalini.
Yeah, thanks. I just wanted to jump in here because one topic that's kind of top of mind, at least in my role, is looking at how different sectors of the industry that touch healthcare might work together. This isn't a problem or an issue that can be solved by any one facet of the healthcare system. For example, healthcare providers or institutions or payers or the government. But there is an opportunity to form these cross-sector partnerships, and that's where we can really catalyze true change that's meaningful. And I think that's an area to explore. I think that we haven't successfully worked together across the healthcare space to successfully achieve results for patients, and there's the greatest opportunity for the future.
That's an excellent point. Rosalind, would you like to comment maybe on some of the things that we can do beyond data collection that will impact change? And are there any questions that you feel that actually we should be asking that we are not currently asking?
Yeah, I think more, and I'm going to piggyback on what Shalini said, because that's the same thought that I had, and I alluded to earlier, is really as we have these conversations about change, who's at that table, right? So who are the key stakeholders that we need, and really making sure that the folks that are discussing the issues are the ones that are needed. Because oftentimes we have these grand ideas of programs, of things that we want to do, but we're coming from a different level than the community. So really emphasizing, I'm just want to emphasize that we need the community at the table. And I'm a big advocate for community, right? We need them. We need their voice. We need their stories. We need organizations who are the ones doing the legwork, right? So, the ones that are going into homes, that are really interacting with people. What are they experiencing in the front line, right? We need those experiences all collected as we continue to move towards change in the way we collect it and the way we interpret the data.
Thank you so much. And I'm going to go to Moke on that question finally. Are there any things, any topics that we should be thinking about, or any questions that we should be asking that we are currently not really asking?
Yeah, I want to also add here, in addition to what everyone is saying, is that we need to generate more opportunities to listen and hear from the patients about their experiences. This is what we often don't do much, even though we collect information about them, because most times, especially maybe in the US or other areas where we see racial disparities, what we also see is that people of color are not adequately being listened to, especially in clinical settings. We've seen stories out there showing that they are not being listened to. And this is one of the things that we need to do, like give them opportunities to share their experiences, incorporate a patient experience metric into the data that we currently have. And another thing that has been going on in my mind moving forward is, we've been talking a lot about incorporating social determinants of health, but there is also a measurement problem. There is the upstream, measuring this upstream has a lot of potential, but the question remains, where do we go from here? And we know that the first thing, if we need to get this thing right, we need to have the appropriate data set, appropriate data elements. Is it standardized enough? Do we know how the metrics for housing should be, metrics for food access should be? So these are some of the things that, in addition to all the things that we have been collecting, we need to incorporate some of these things into health outcome data to see the holistic picture. I know I'm taking a little bit of time. Why? Because 80% of the health outcomes actually is dependent on the social and economic factors. That's the SDOH. The other 20% is just based on quality of healthcare services. And this is why we need to focus on this particular area. How do we measure it? And how do we standardize it? I know that a lot of people are doing several other things. How do we come together and have like a proper measurement that would tell us what is going on?
Thank you for that, very insightful. I'm going to come to my final question, really, and this is really looking forward with more hope. So if we consider sort of in the next 3 to 5 years, what are some of the biggest changes that you really hope to be able to see? And is there any data specific that needs to be collected in order to support that? I'm going to start with Rosalind on that question.
Sure. So one thing that is happening that I'm excited about is CMS, the Centers for Medicare and Medicaid Services in the US, is actually starting from 2024, is mandating that hospitals have to start collecting social determinants of health data. And once they collect that data, they have to now connect those individuals to the resources that they need. Right now, it's not really required, but it's going to be mandated moving forward. And that's exciting to me because not only are you collecting this data, now we're moving from collection into action. So someone comes to your hospital, they need food or they need housing, you collect that data, you screen them, you collect that data, and then you move that into whatever they may need. So that for me is exciting. And I think that's like, my fingers are crossed that it's going to work out well, because if it's a mandated requirement, then we kind of have no choice but to do it, right? So that's one thing that I'm hopeful about.
Thank you. Khadija, what are you most hopeful about looking forward into the next 3 to 5 years, and how can we support that with data?
Oh, I'm most looking forward to basically ensuring that key voices are centered around the table where key decisions are being made. So whether that means including not just patients, but maybe grassroots organizations who utilize the data to come up with solutions, having their voices at the center, ensuring that they do receive the necessary sustainable funding to continue the work that they do in order to make sure that there are better outcomes. So just to summarize, it's ensuring that we have more involvement of those on the ground who do the work day to day, most often voluntarily, because it really affects their communities, and we need to see them more appreciated.
Thank you. I'm going to go next to Chinwoke to sort of hear about, your hopes for the future.
Yes, this is a good opportunity for me to remind everyone that race is a social construct and not biological. I'm going somewhere with this. A lot of times where, especially in areas where racial disparity exists, we see ourselves just measuring race. We should be bold enough to measure racism. Racism is the underlying factor, with all most of the disparities that we see. I know that I measure race, just because I don't have that measure of racism in some of the work that I do. But going forward in the next 3 to 5 years, these are the kind of data that we want to see researchers, public health implementers, clinicians measure. People should be bold enough to measure racism and not just use race as a proxy, because one, race is a social construct and not biological. So we need to keep reminding ourselves that we should incorporate more information on racism, because if you want to deal with this disparity, we need to collect the information on that. And information on race alone doesn't tell us the whole story. And this is what I would love to see going forward. I'm trying also to do that in my own area of work. It is difficult, having all those measures, getting standardized measures for racism, but this is what we're encouraging health equity experts out there to start doing. And we want to see more.
Yeah, so that's great, being bold and not shying away from those difficult questions and discussions. So finally, I'm going to come to Shalini. What are your hopes in terms of what would you like to see over the next 3 to 5 years, and how can that be supported, or can it be supported indeed with data?
It's hard to follow my fellow panelists. I'm so inspired by the answers that they shared, and especially Chinwoke around the objective measures that we can put into place. So we need to have a paradigm shift on what we focus on or prioritize, or how we measure success. And I look forward to seeing how health authority kind of guidance documents get implemented into true strategy that influences who is able to participate or who has access to participate in clinical trials, to see more representative clinical studies be conducted. Historically, a lot of the metrics that are used as success measures for clinical trial execution don't focus on patient inclusivity or centricity, or around representation. And I like the challenge, Chinwoke, that you put out there, is that we're currently measuring race and using that to measure success, but might we measure something different? Because we might as well, leapfrog over. We've been using in our field in medicine, race historically to categorize in patient demographic data, but might there be other variables that we should be focused on to collect? So I'm excited to see where all of this evolves, and also all of the very passionate professionals that are in this space that are taking very bold action to change the trajectory of healthcare in the future.
Thank you. And thank you, panel. It has been a really interesting, a really inspiring discussion. It's great to hear your points of view, and it gives us some hope that at least we have various individuals who are already starting to make the change that we need to see. We've sort of explored today, some of the hindrances and the barriers that have prevented, adequate addressing of health inequities in diverse populations. We've talked about how we might move forward, and that we need better study designs, but study designs in themselves not being sufficient. We actually need to have an inclusive approach so that the community are more empowered to engage with those improved study designs. We've talked about ensuring that we address things such as health literacy, as well as social determinants of health. And unless we start to address those, we won't actually begin to see the enhanced and improved data that we need. But we've also heard that maybe we need to think differently about data. You talked about data sharing and about how we can best come together, different stakeholders, to actually share and better utilize the data that we have. But also, might we think a little bit more about different types of data, such as qualitative data. But the statement that I would like to leave in closing, which is one that really resonated with me, was be bold. And I think that that can go across all of the various topics that we have discussed today. We need to be bold. We will not effect change by shying away, but we need to be bold to address the difficult conversations and to challenge the stakeholders that we need to challenge in order to impact a real change. So with that, I'm going to thank our panelists again, Dr. Chinwoke Iziguzo, Rosalind Ate, Dr. Khadija Owuzo, Dr. Shalini Mohan, for your inspired contributions today. Thank you very much.
Thank you for having us.
Yeah.
Yeah.
And also I will thank our audience for your attention today.